I would like to go over some insertion techniques that will simplify the successful placement of the airway on the first attempt. The standard technique is the mandibular lift, where the airway is placed into the pharynx and around the posterior pharyngeal wall and into the hypopharynx. This is a standard method of placement in anesthesiology where we have a fully anesthetized and relaxed patient. But this doesn't do the topic justice when we're talking about the pre-hospital use or the emergency use of this airway. If difficulty inserting the iGel is encountered on the attempt using the standard mandibular lift maneuver, a laryngoscope is permitted in most services to help place the supraglottic airway. So I'm going to just visualize the hypopharynx with this video laryngoscope, and so we're just going to show basically the hypopharynx. I'm going to use this as a distracting tool to place the supraglottic underneath the tongue and larynx into where the tip of the supraglottic goes into the upper esophageal inlet. And you can see as I relax the laryngoscope that the epiglottis rests on the heel of the airway, and this is going to permit me the ability to have a great position and seal now. What I'm going to recommend is, in lieu of utilizing an actual laryngoscope to place a supraglottic airway, we investigate the use of a preemptive suction maneuver that utilizes a rigid suction catheter. In this case, this is a large bore rigid suction catheter. A Yankauer will work, but this is a Ducanto. This is quite rigid, and it's anatomically shaped. This can be utilized in the same manner as a laryngoscope to pin the tongue into the floor of the mouth, distract the mandible inferiorly, to lift the base of tongue off the posterior pharyngeal wall, and to assist the insertion of the supraglottic airway. You're going to compress the tongue into the floor of the mouth, lift the base of tongue off the posterior pharyngeal wall, and you're going to place the supraglottic airway by placing your index finger on the 15mm connector, which puts the vector of force along the long axis of the airway so that it can scoop around the posterior pharyngeal wall and into the hypopharynx. I'm going to demonstrate the use of the suction-assisted supraglottic airway insertion in the setting of a contaminated airway. Our mannequin here is full of simulated airway contaminant. I'm going to turn on my suction, and what I'm going to do is decontaminate the oral pharynx and then the hypopharynx. And then I'm going to compress the tongue into the floor of the mouth, lift the tongue off the posterior pharyngeal wall, and place my supraglottic airway. Before I ventilate the patient, I'd like to suction this airway to ensure that I don't have a contamination of the ventilation channel. There's two ways to achieve that. I'm going to recontaminate the iGel just to make a point here. Okay. We can see some airway contaminant coming out of the drainage channel. I'm going to be using a flexible suction catheter down the supraglottic airway now. And now we're ready for ventilation. A faster technique to decontaminate a contaminated supraglottic is something I call the rapid airway decontamination, or RAD maneuver. I'm going to recontaminate this airway. There we are. And in lieu of using the flexible suction catheter, I'm going to demonstrate a technique to use the rigid suction catheter. I'll place the rigid suction catheter into the airway, and I'll form a seal with the ring of my hand around the 15mm connector. This is a rapid airway decontamination maneuver that essentially uses the supraglottic as a suction itself. And as you can see, our test lungs deflated a little bit as I did this, so I know I have a seal. During periodic ventilation of the patient, this can be a rapid way to decontaminate the ventilation channel during clinical use. To further illustrate the suction-assisted supraglottic airway insertion, I'm going to contaminate the mannequin under direct video guidance here. So we have a contaminated hypopharynx, as we can see. I'm going to put a little bit more airway contaminant in here. Okay. So the patient's going to aspirate at this point if I ventilate the mannequin either with a face mask or with a supraglottic. I'll have to suction this patient before I can adequately place a supraglottic or face mask ventilate. We're going to use the suction-assisted supraglottic airway insertion method now, where I hold the suction in my left hand like it's the same shape and contour as a laryngoscope. Push the mandible down, place the suction around the base of the tongue to decontaminate the hypopharynx. And now I'm going to push and lift and place the supraglottic airway. Let's just have a quick look and see how much I've decontaminated already just with that little maneuver. I've decontaminated the hypopharynx. It's pretty dry in there. Push the tongue into the floor of the mouth, lift the tongue off the posterior pharyngeal wall, place the supraglottic airway under the epiglottis. And before I ventilate, I'm going to want to suction the supraglottic. Two ways to do that, of course. The first way is with a flexible suction catheter. Second way is the rapid airway decontamination maneuver, or RAD, where I place the rigid suction catheter into the 15mm connector, make a seal with my hand, and I just use literally use the supraglottic as a suction catheter itself. I also call this the cornholio maneuver because we are making a little artificial sphincter. Let's go ahead and give our mannequin a couple breaths here. I'm going to recontaminate this airway quite substantially to demonstrate the rapid airway decontamination maneuver again. Now I'm concerned more about the contaminant that spills over the bowl of the mask and into the ventilation channel than I am the contaminant that goes under the mask and out of the corners of the mouth. So what I'm going to start with is the rapid airway decontamination maneuver, otherwise known as the cornholio. I'm going to decontaminate the central ventilation channel, and then I'll go ahead and decontaminate behind the mask on both sides like I would with an oral airway. And I can safely ventilate the patient without forcing aspiration. What I want to introduce here is the use of a manual suction device in lieu of a electronic suction device. And we're going to look at something called the SEADUC, which is a combination of a device called a Suction Easy with a scored Ducanto catheter. We're going to go ahead and open up our device here. We have the Ducanto catheter, and we have the Suction Easy product itself, which has been shortened to become what we call the SEADUC. You take the Ducanto catheter out of the package and put it straight onto the suction device itself. And what this is going to allow us to do is anytime we need suction, this device is going to be there for us. So let's recontaminate this airway and do this simulation from the beginning. We're going to really muck it up here. Okay, you can see the mannequin's got a full mouth of airway contaminant now. I'll begin by introducing the Ducanto catheter into the mouth and squeezing and releasing this bulb, which is very effective in evacuating airway contaminants. And what I'll do now is I'll push this rigid suction catheter into the floor of the mouth to distract the tongue into the floor of the mouth and lift the base of tongue off the posterior pharyngeal wall. I'll place the supraglottic airway fully into the patient, and I'll finish the insertion with the rapid airway decontamination maneuver. I'm able to thoroughly decontaminate. So I have probably about 150 milliliters of airway contaminant here. What's important to note is that many of these portable devices hold much less than the capability of this device. This device is capable of holding 1,000 milliliters of airway contaminant. It's also capable of aspirating large particles. What I'm going to demonstrate is the use of the portable SEADUC suction system to decontaminate the airway, assist the insertion of a supraglottic airway, and rapidly decontaminate that supraglottic airway. I'll start with the squeezing device in my right hand, the bulb, and I'll place the large bore suction into the mannequin and begin decontaminate the oral pharynx. Squeeze and release, squeeze and release. What I'm going to do now is I'm going to push the tongue into the floor of the mouth, distract that base of tongue off the posterior pharyngeal wall, place the supraglottic airway all the way into the mannequin. And now I'm going to perform a rapid airway decontamination maneuver just by using the device to decontaminate the ventilation channel. This round hole here allows us to burp air out of the device until the diaphragm that covers these holes becomes wet with airway contaminant. Now the device will not burp anymore, so it doesn't spray airway contaminant on the rescuers. The bag can hold up to 1,000 milliliters of fluid. And so here we have a patient that's been resuscitated, and now we can ventilate him. Beautiful.